Hello, my name is Byung Hwang. Today my topic is minimalist TAVI in CMC. And current TAVI indication is going more and more towards younger and low-risk patients. And in 2014, there has been this journal about minimalist approach versus standard approach. And it showed that the minimalist approach has outcomes similar to standard approach. As you can see in this journal, the length of stay and cost is more better in the minimalist approach than the standard approach. And after the treatment, event-free survival is similar between two groups. So in Korea, we are doing not every group is doing minimalist TAVI, so I'm going to introduce the concept of minimalist TAVI today. So minimal sedation, and there is the tendency to general anesthesia. If we go to general anesthesia, we get intraoperative TE, but in minimal sedation, we do not do TE, but ICE or TTE. So we have to do a pre-procedure workup. Procedure towards same-day discharge or next-day discharge. So how are we doing this minimalist TAVI in CMC? We're doing monitored anesthesia care without general anesthesia, and we do not need anesthesiologist. And we do only one femoral puncture and LV wire pacing, and we use ProGlide plus Femosil instead 2 ProGlides, and this all leads towards early and safe discharge. So this is our protocol. We do this in this cat room. We train the nurses to do this monitored anesthesia care. So using midazolam and fentanyl, we watch the patient in 5 minutes. And if the sedation is not insufficient, then we give the patient more medication. So in this journal in 2019, monitored anesthesia care versus general anesthesia was published. And as you can see, monitored anesthesia care has length of ICU stay and total hospital stay is lower than the general anesthesia. And as you can see, total anesthesia time is shorter, and procedure time is shorter in MAC. But in the device access and early safety and clinical efficacy, there is no difference between two groups. So we can do monitored anesthesia care safely in TAVI patients. We use only one femoral puncture, and we do LV wire pacing, so we do not have a femoral vein puncture, and we use radial puncture for a pigtail. Why we do this is that putting a 16 French sheath in the femoral artery, sometimes the pigtail can get skinked in the distal aorta because in this distal aorta, there's very stenosis and calcification. So manipulation in the 16 French pigtail is difficult when we use a large sheath. So this is our procedure. One radial puncture for radial pigtail, and the femoral puncture for main device. And there is this puncture needle, radial puncture needle in the subcutaneous for the wire pacing. And temporal lead can, there are some cases that temporal lead can make some tamponade. And there is some cases that this tortuosity, putting the temporal lead into the RV is sometimes needs some work. So this balloon tip can make the temporal lead go into the RV better, but sometimes it's very difficult to the severe tortuosity and the compression of the vein. So we are doing LV wire pacing to this alligator clip, as you can see in the clip, one clip is into the sapphire wire and one clip is into the wire needle. So this is the sapphire wire, and this is the negative alligator, and the positive alligator is clipped into the wire, the needle, puncture needle in the subcutaneous. So this is the procedural clip. As you can see, this radial puncture needle is inserted into the opposite subcutaneous, and one clip is clipped into the needle, and one clip is into the sapphire wire. And after that, we are testing the pacemaker, and it goes rapid pacing. After that, we had TAVI. So this journal takes about direct wire pacing versus RV lead pacing in the easy TAVI. There were 152 groups in both groups. And as you can see, direct wire pacing has a procedure time more shorter than RV lead pacing. Relative time reduction was about 12%. And secondary endpoint was radiation exposure, and fluoroscopy time was shorter, and the radiation was lesser. As in the efficacy, procedure success was 100%, and the stimulation efficacy was almost similar. And in the secondary endpoint in MACE, as you can see, there was lesser MACE in the direct wire pacing groups. This was not statistically relevant, but as you can see, direct RV lead pacing can cause more tamponade, 2 RV perforation, and 2 annular rupture. This is our case doing TAVI with LV wire pacing with a balloon expandable valve and self-expandable valve. Both valves we can do safely with LV wire pacing. Finally, we are using a ProSeal. In using 2 prolides, there are about 1 or 2%. 2 prolides can cause the stricture in the puncture site. So after that, the stricture in the puncture site, it cannot be treated with endovascular treatment. We have to do surgery and cut down the prolide. But we are now using 1 prolide and put the femoral seal into the prolide and make the femoral seal into the prolide. So this is our clip of doing this image. Put the wire and insert the knob, the longer one first, and put femoral seal deep and put both knobs into the femoral seal. Then put the femoral seal and clip the femoral seal. It can be done relatively very easily than 2 prolides. So this is my take-home messages. Minimalist TAVI is not the future, but it's the current. And we use minimal conscious sedation. And there's only 1 femoral puncture and LV wire pacing using prolide and femoral seal. All leads towards early and safe discharge. After doing minimalist TAVI in CMC, we are trying to do next day discharge. Same day discharge after TAVI. It's some things yet to be considered in Korea. Thank you for your attention.